I'm very excited to present some of the work that we have been doing in the U.S., discuss some of these innovations. For example, I've put here the United Kingdom. You can see we're 2 to 3x in terms of spending per capita, and we're embarrassingly higher than what we're seeing in India, where you can barely see the sliver here. If we look at percentage of GDP, we see similar numbers, though on a slightly smaller scale, but we see almost 17% of our GDP is spent on healthcare. A staggering amount of money. And it's unclear as we look in the United States, as people have said, what is the greatest challenge in the U.S. in terms of competing in the global economy? Many have pointed to this. Because we spend so much here that we lack money for infrastructure, education, and other items. And that many policymakers say, if we don't fix this, the U.S. economy will go decline. And so it has become of paramount importance. If we spent this much and then we got better health and we were all living long, this would be fine, but that's not the case. And I think many of you are aware of this. Many of you have seen this graph. This is showing the amount of spending per capita on the x-axis. The y-axis is years of life from birth. You see the U.S. as being a huge outlier here. And yet, it isn't following the curve where we are actually, our life expectancy is lower than we might expect based on this. And this as along with many other research that has been done in similar veins, saying we are not getting the care that we need from the amount of money we're spending. And so there's been a thought, what do we do to fix this issue? And to make matters even worse is that you would think if we're spending $9,000 per person per year, there would be healthcare everywhere. And that is not at all the case. This is a map of the United States where I'm mapping a certain, just one specialty, endocrinology. And we see, where are these endocrinologists located? All the endocrinologists want to be in big cities. So we see here in our eastern seaboard where they are in California and some of our other cities. But there are large areas of the United States where there are very few endocrinologists and patients struggle. They have to drive several hours to go see a specialist. This is just one specialty, but this is consistent across all of them. If we look at even more narrow areas, such as we've done some work, 66% of the country in geographic area lacks any pediatric specialist. People must travel several hours. So we're spending so much money, yet people can't access the care that they need. They need to drive large distances. And to exacerbate the issue is that we are lucky in the United States that over now, with many of our changes, we have more than 90% of our citizens have insurance. But that insurance does not come in the same type. Most of our children now have government insurance. And we've done auditing studies where we have called up offices and pretended to have government insurance versus private insurance. When we say we have government insurance, they say we don't have an appointment 2/3 of the time. When we say we have private insurance, they 11%, only 11% of the people were told that we don't have a timely appointment. So the type of insurance, even if someone is available to you, to get in is terrible. And we also have the issue that 45% of our psychiatrists in the United States are say cash only. You have to come to us, you have to pay out of your own pocket. If you don't have the money, you can't afford it. And now, obviously, only the wealthy can afford to see a psychiatrist. When a particular issue in the United States, because we lack, in many cases, available treatment for mental health. So this is the paradox of the U.S. healthcare system. We spend so much money, yet we're not getting good outcomes, and we still have patients complaining that they can't get in to see someone. And this is particularly true for specialty care. We have, in 2016, so much research happening in the United States, elsewhere in the world, about trying to develop new ways and new treatments. What does that mean for the average physician? It means they can't keep up. So many times, and increasingly, a physician will see a patient in front of them for primary care and not know what is the next step to do. And so therefore, at the same time, so many people lack the ability to go into see a specialist. We're seeing an increasing need. What I'm showing you here is from 1993 to 2009. The number of visits in which the primary care physician said, I'm not sure what is going on, I think I need to see specialty care, and that number has doubled. Because there's so much to know. How could any single physician know what to do? So what to do? This is the struggle. And in many cases, most of the policy discussion in the United States about how do we fix this problem has really focused on We need to pay our hospitals, our doctors in different ways. We need to change the way that we provide insurance in terms of the benefit design. And you may have heard that in the U.S. we have another experiment. We're making our patients pay more and more out of their own pocket. And we're also spending a lot of money and effort trying to say, to go to our hospitals, go to our doctor's offices, go to any other care site. How can we improve the care you provide? But there are many in the U.S. who are arguing this is foolish, in the sense that this is not the way that we can really make the changes that we need. The real way to drive change in the U.S. healthcare system, and maybe internationally, is that if you try to improve the care, you go to a doctor and say, will you improve your care, you'll get marginal results. But the way to change it is to provide the care in the new way. And people look to other industries. They look to banking, for example, and they say, banking didn't change because we went to the tellers and said, tellers, please do your work a little bit more efficiently. No, we used both ATMs and internet banking, and that made that big leap in terms of care that needs to be provided. And so the idea here is, can we do similar work in healthcare? This has been promoted by one gentleman in the U.S., Clayton Christensen, who has brought up this idea of disruptive innovation. And what he looks across all industries, he sees a similar theme when we look at things from motorcycles to steel to any other industry. The change did not come from going to the existing companies or providers and saying, hey, we need to make you do things better. It came from someone new entering that market and providing the care in a new and different way, usually by focusing on the simplest services and using technology or lower salaried employees to provide that care at a cheaper price and therefore enter that industry and really change things. And so again, in U.S., the idea is, can we take the same idea and apply it to healthcare to fix that quality, cost, and access issues that we're seeing? So what I wanted to turn with you is just to give you kind of a menu or a little sampling of a number of those innovations. And then after that, I'll go in terms of some of the lessons that we've learned as those innovations have sort of begun to spread. So the first one I might mention to you is it was retail clinics. In the U.S., it's always been that you go to a doctor's office to get your care. But increasingly in the U.S., we're seeing clinics within the stores, the retail stores. This is a grocery store. So right next to, and you'll see this in drugstores and other stores, right next to the milk and the eggs and everything else is a clinic. And that clinic is staffed and has some unique characteristics. First, this care provider, she is not a physician. She is a nurse practitioner. That means someone in the U.S. who went to nursing school and then several years of training afterwards. And in the U.S., increasingly, a nurse practitioner can practice independent of a physician. So first, it's lower cost. It's located in a very convenient location. Everyone goes daily, weekly to the store to buy their food or anything. And now they know this location. It's very convenient, 7 days a week, open anytime you walk in. And it has a pharmacy right next door, so you can get your prescription very quickly. They also have, it doesn't provide all care. They have a menu. This is also something very unique in the U.S. When you go to a doctor, you go for any problem. Here, you can only go for certain problems. You can go to see if you're worried you have a urinary tract infection, your sore throat. You can get your earwax removed. All of these things, and it has a price right associated with it. And we're seeing these clinics, 2,000 of now, spread across the United States, growing quite rapidly in terms of a new model of care. And I'll just come back to the retail clinics a little bit later in terms of some of their impact. But we're also seeing at the same time, these clinics that are stores, we're also seeing increasingly interest in direct-to-consumer telemedicine. What does this really mean? 7 days a week, 24 hours a day, a physician will come on your phone or your iPad or whatever tablet you might have. This is the screenshot. This is the physician. This is the patient. They have an interaction. He or she will ask you many questions, sort of do an exam by looking at your rash through the video, and then diagnose you. And then send, if you need a prescription, to a pharmacy close by, and you can get your prescription filled. Again, 24 hours a day, 7 days a week. What do they manage? These are the problems that people are managing via direct-to-consumer telemedicine. Urinary tract infections, your back is bothering you, you might have an eye issue. These are the kinds of problems that people, at any time of night, they cannot get into a physician at a timely manner. It's very nice. You're in your home, you come, maybe you have a sick child, you can quickly get care in a new way. But beyond that, we're seeing even people who are pushing the envelope even more within the US. This is one company called, a clever name, Lemonade. They say, so many problems that we have in healthcare, why do we even need an interaction between a physician and patient? For something like birth control or acid reflux, this is an algorithm. So the physicians who run Lemonade have created an algorithm. A patient will go on to the website, answer a series of questions about what the problem is. For example, a woman who needs birth control, which is a real issue in the US. We don't have enough access to that. She might say, oh, have you had a history of blood clots? No. Have you had any other problems? If everything is a no, then she will get a prescription sent to her pharmacy. She'll indicate which one, and no interaction with a physician. If there is a problem, if there is a issue, then the physician will call the woman and discuss. But a very small fraction of the encounters require an interaction. And so they say, look, we can do 10,000 visits in a day with one physician. Because most of it is just algorithms, so the computer is doing it, and the small number of cases that need some discussion we'll just take care of. And therefore, for $15 US, 24 hours a day, 7 days a week, you can get care. But this is all for basic problems. We're also seeing it for specialty care. This is an example of something for dermatology. That's an issue also. You go outside of the large city in the US, it's very difficult for you to find a dermatologist. What if you have a rash or another issue? Similar thing. You go, and here is very interesting. You go to a clinic. It'll say direct dermatology there. You'll walk in. You don't need an appointment. A nurse will take you to the back. She will ask you a series of questions. What's going on with your rash? How long have you had it? Is it itchy? She'll take photos. And then she'll send those off to a dermatologist hundreds of miles away. He or she will respond, look at those things within 24 hours, respond to the nurse, and then the nurse will call you and say, this is the treatment plan. Here are the prescriptions, etc. No encounter, no interaction with the patient, with the doctor, but all of this is done remotely, and the physician can do many of these very rapidly from the comfort of his or her home. Two more that I wanted to give you in this kind of sample of some of the innovations we're seeing in the US. One is also eReferrals. Here is driven by the fact that we so much, I see a patient, I say, I'm not sure what to do, I'll send you to a specialist. How difficult is that for the patient? They need to make the appointment, they need to take time off from work. And so many of those interactions, they don't require a face interaction between the physician and the patient. It's just 2 minutes. For example, I might have a woman who has a thyroid issue, and I'm not sure what to do about the problem, the blood tests are abnormal. I send a little message to one of my colleagues. The specialist reviews it within 1 to 2 days, and if everything is straightforward, he'll respond without a visit. He'll just say, oh, you're fine, increase the medications. And so people get answers quickly without any interaction, and I pay the specialist $25 for that consultation. Or he or she will tell me, just do this test. But again, the patient does not have to go there and have that delay in getting care, and it can be done cares more efficiently. Last but not least, I wanted to introduce one other innovation we're seeing, which are called symptom checkers. And this is saying, why do we even need any provider involved at all? What symptom checkers are trying to answer the basic question that almost all of us have all the time, which is, what might be going on with me? And maybe more importantly for most patients, do I need to take time off of work or do what I'm doing to go see somebody? Or is this a basic problem? And so you see symptom checkers that have been introduced by my own medical school, the National Health Service in the UK, Australia has those, many private companies have developed them. And again, the way this works is you go to a website or your smartphone, you say, what is my problem? My chest hurts. They'll ask you many questions. And then the algorithm, a computer algorithm fully, will tell you these are the problems that could be going on for these different things. And again, hey, go see a doctor right today. Go care right now. Go to the emergency department. Or maybe this is something you could stay at home for. So these are some ideas and some of the innovations in delivery that people are trying to address, again, the cost, quality, access issues. Let me now tell you a little bit about what impact they've had. The first is, it's been remarkable. These have all developed mostly in the last 5 to 10 years, and already we're seeing significant growth. Year over year, 25 to 50% increase in number of visits. We're seeing now over 10 million retail clinic visits a year, 1 million of those visits that are occurring via smartphones, 200,000 eReferrals where people are messaging, specialty referrals conducted via video. And these symptom checkers are extremely popular. Our own analyses say about 200 million 200 million uses of such tools every year worldwide. And again, growing rapidly. I should emphasize, though, that even though these numbers look quite large, in contrast to the 1 billion visits we have in the U.S. every year for doctor visits, these are still small, but they are growing rapidly. One of the things I think is most interesting about these kind of innovations, they have challenged so many norms in the U.S. Of how care is divided. Physicians, including myself, have always been king in the United States. But here, increasingly with retail clinics, they're emphasizing non-physicians as being the care provider. In the U.S., healthcare has always been unique. I see the patient, I figure out what's going on, and every patient is different. These innovations have taken a very different model, which is automation. Many things are basic. Let's just do them in an automated manner, and we can do things more efficiently and potentially with higher quality. They also take the mantra of many of the companies in the internet startup mode that we see in the US, the Googles, the Yahoos, the Ciscos, and other companies, and many of the people from those companies have come into healthcare. And they have a very different mentality, which is we need to do this quickly, we are for profit instead of non-profit, and we need to grow rapidly. And instead of being, always in the US it's been, I have a hospital for a certain town, I'm serving a certain a city, or my ophthalmology practice is for a certain city. They don't think this way. They think I'm national in scope or international in scope. Those visits for telemedicine, they happen in all 50 states. And again, with that large 350 million people they can serve, they can grow much more rapidly than a single hospital or a certain clinic could do. And they fit into this disruptive innovation model because they're affordability. I'll get into the price in just a moment. Convenience, simplicity to previously neglected markets. And again, they're using less expensive providers, cutting overhead. They don't need to have a building, a big hospital that they need to heat. And they're also using automation. So what I wanted to now wrap up with was some thoughts on what have we learned so far as these innovations have come on board. It's all very exciting, very interesting. But there are places these work well, and these are places that they don't work well. Let me provide some insights into that. The first has been when these innovations came on board, the physician community, the medical community, the policy community said this is stupid. How can you provide care via a phone? Or how can you provide care via a nurse in a store? This is idiotic. Our work and other work has found that surprisingly, when we've compared the same visit for a patient who goes, for example, in this case it's a retail clinic, versus a patient who goes, the same type patient who goes to a physician office or an emergency department, an emergency department in a hospital, for the same problems, we look at one of the issues the physician community said, the nurse doesn't know anything, she'll just prescribe antibiotics. When we look at the antibiotic prescribing rate, we see it's very similar between those sites. We look in certain areas. In the United States, there's much concern that we are overusing antibiotics, in particular certain kinds of antibiotics. And in this particular case, though the difference is relatively small, the retail clinics are superior in terms of the quality of care that they're providing. Very surprising for the physician community. There's also a thought, how can any nurse she'll misdiagnose the problem. When we look at those patients and we see follow-up to see, hey, maybe if they were misdiagnosed, they would go and end up seeing somebody else. And so we follow them for 6 weeks, and the number of patients who go to seek any follow-up is identical comparing retail clinics versus those who go to physician offices. So again, very surprising that these clinics, despite their controversy and concern, the evidence has not borne out that they are providing poor quality. This is also true here in some of the video visits that people have had, where we're also, again, comparing what fraction of the patients get antibiotics. The thought was when you can't examine the patient, you can't listen via a video, you're going to overprescribe antibiotics. Again, surprisingly, we do not see that's the case. That is not to say, so let me also say that this is not just our own work. Others have found that patient satisfaction is very high. You go to a doctor's office, it seems so quick. The doctor spends 2 minutes with you. Here, they spend more time often, so people are more satisfied. In terms of follow-up visits rates and how consistent care is with guidelines, also the care has been proven to be high quality. But there are issues. I do want to emphasize that not all care. Some people say everything is going to be on the internet or your smartphone in 10 years. And that's not the case. We should emphasize that. In terms of the teledermatology, the direct dermatology, about 20% of those visits, the dermatologist looks at the picture, looks at the history and says, I don't know. And says, you need to come in to see me directly. So it's not everything. 80% they could diagnose, but 20% of the time they cannot. And also, in the U.S. in particular, we use tests a lot, and those tests are very useful in terms of making diagnoses for, say, a urinary tract infection. And in those cases, how can you make a urinary tract infection diagnosis over the internet? So there's also some concerns that they might be expanding their care too broadly. I also wanted to describe some work that we've done looking at whether so other people have said, hey, computers, we're in 2016, everything's going to take over by computers, we don't need doctors. So we wanted to evaluate how effective those symptom checkers are in terms of making diagnosis. So what we did is we used a series of clinical vignettes that we created. This is an example of a young girl who has severe pain, nausea, vomiting, diarrhea, fever, no bowel sound. So a very concerning case for potential appendicitis. And what we did is we pretended to be her and 45 other clinical vignettes, and we went to all the symptom checkers in the world and saw how often are they giving us the correct diagnosis, either listing it first or in that long list in the top 3 or in the top 20. And what we find is, maybe not surprisingly, that going to medical school does help in the sense that only 33% of the time were they giving the patient the right diagnosis listed first, and it's about 52 and 60%. And when we look at this compared to physicians, they're around 80%. So they're not perfect. 80% is not 100%, but they're close, much better than they are here. So lessons learned on the quality side, we're seeing surprisingly the quality is often comparable to office-based physicians, but limits in terms of what can be provided. And we also, computers may be helpful, but they have certainly not replaced professional judgment yet. I wanted now to turn quickly to the access issues, because that's been one of the key drivers of this. There's so many parts of the U.S. where we cannot get people, there are no providers to see. What we have found is that these for-profit companies that have introduced retail clinics and direct-to-consumer telemedicine, when these have been introduced on the market and available to everybody, it has not been, surprisingly, those who are in the underserved communities who are most likely to use it. We find few of these retail clinics are located in rural communities or in areas with few physicians. They're usually younger, more educated patients, wealthier patients who are actually using these, as opposed to what I think many had hoped, which was to be those who are the poor, those who cannot access care. This is also consistent with the smartphone visits, where we see what fraction of the patients are in a rural community, a relatively small fraction. And they often live relatively close to a physician's office or a hospital. So it has not proven to be that you just introduce this innovation out there and the poor in the rural areas were going to use it. It's actually often the people in the cities who are actually the ones who are going to use this and may have a smartphone also. And so it may not offer improved care to everyone, and a targeted approach may be necessary. One of the large insurers in the United States said, okay, we're not going to offer it to everybody. We're only going to offer it, this video visits for specialty care, to those who live in rural communities. We will say only those who, a physician must request that specialty care, and the patient must go to the physician's clinic to actually get the care. And there we see it does seem to improve things. Not surprisingly, 100% of the visits are in rural communities, 83% of the patients are in poverty, and 63% of them are disabled. So in this targeted approach, in contrast to just providing to everyone, was successful. And that might be something very critical as we think about how these innovations are going to drive improvements in access. And last but not least, I wanted to wrap up with some of the lessons we've learned in terms of what's the impact on costs. When we look at these innovations and we compare them on a per unit basis to going to a doctor's office or ED, they are much cheaper. A physician's office visit in the United States costs approximately $150 to $180 US per visit. Extraordinary, a large amount of money. When we compare those who go to a retail clinic, about 30 to 40% cheaper. And if you go to an emergency department, 70 to 80% cheaper. So per unit costs are much, much lower in this example. And we see that also among some of these others. Telemedicine visits via a smartphone, $40, which is cheap for the United States. These algorithm-based visits, $15. And if you use a symptom checker, essentially free because it's just a computer doing this. And so this has generated a lot of excitement. Maybe this is a way that we can fully address this $9,000 a year that we're spending on healthcare. Maybe we can cut costs this way, and this will be a more efficient way of delivering care in the United States. But that we have to, I think many people who have focused on that have not thought this through fully. Because if you are going to use these innovations to decrease costs, what you are assuming is they are going to substitute for someone to go to a doctor or an emergency department. And if you follow people over time, you will see that their utilization of number of visits per year is about the same. It's just different where they go for care. They're going to go for this smartphone or retail clinic. But you could also have the issue that basically these are more convenient. So patients who otherwise would have stayed at home would have now go out there and get care. And if you saw that, you would see if over time you will see increases in the amount of care that is received. We evaluated that before and after in retail clinics by looking at two populations, those who are going to retail clinics and those who are not. And we did some matching and other things to determine that. And we looked at overall utilization for problems that can be managed at retail clinics. These are the simple problems. And what we find is this is data from 2005 to 2009 here. These are the number of visits per 1,000 per month. And we see before the retail clinics opened in these communities, a very similar level of utilization. This is the period when they all opened. And then what we see among the retail clinic users is a dramatic increase in utilization. They're now getting care more. They are less likely to go to a doctor's visit. This is the number of visits to physicians. But most of the care seems to be new utilization. And so in other words, what we see is if we look at 100 of these retail clinic visits, 2/3 represent new utilization, 1/3 represent physician office visits that they've replaced. And what we found is contrary to what people had expected and hoped, is that these innovations are actually driving up healthcare spending for these types of problems. We see it similarly for direct-to-consumer telemedicine, where we find that more than 90%, or just under 90%, the math is not adding up, around 90% of the visits are new utilization versus replacement of physician visits. And so they're also driving up healthcare spending. So just really the impact on spending, that so much excitement in the US that these are going to drive down healthcare spending. They are cheaper on a per visit basis, but they also are more convenient, so more people get care. Now, is this bad or good? If this was for problems, birth control, diabetes, high blood pressure, weight loss, where we know more people need to get nutrition, other things where people need care, then we would be applauding. We would be saying, this is great. This is driving up utilization. This is good for our society and our country. The problem is that many of the problems that are being managed at these clinics are things that otherwise get better on their own. Rashes. You're worried you have a sinusitis, sore throats. Let's be clear, most of the time, these get better in a couple of days, and now all we've done is let people who otherwise would have stayed at home, been fine, now go get care and actually drive up healthcare spending. So it really depends on whether the care is actually improving outcomes or not. They're very happy though, yes. That is true. That whenever you take a patient and you provide care to them, they will be happier. And so there is an effect that they are happier and they are getting something out of it, whether the society is getting better in terms of care is unclear, depending on where the care is being provided. So let me summarize, and then I think it'll be fun to have the conversation. There's been a lot of interest in delivery innovations in the U.S. I've described to you how they've really built on technology, lower salaried providers. And while there's been rapid growth, we're still trying to determine how these are really going to play a role. Still learning when the innovations are useful, which clinical problems should we use them for, which problems should we not. They can improve access, but unless we use a targeted approach, they may not be to those who we expect. And they may be, and then also I will say that there are lower per unit costs for going to these such clinics or other innovations. The unclear impact on spending so far. So, I turn it over to you.
So what I'm going to do is very quickly give a commentary on what the possibilities of all these innovations are within the Indian market, particularly from the view of public health, because that for us is one of the driving factors for the government wanting to get into this space. So we will look at a couple of innovations that the government has announced more recently. But what was evident from Atif's talk, and I learned a great deal, is that a lot of these innovations are really happening as market solutions. So it's really in the private sector that we are seeing a lot of experimentation happen. Now, and that is where the question about regulation, what is allowed and what is not allowed, particularly because in healthcare, liabilities are a serious concern. In India, that is probably not the case because there is a large unregulated healthcare sector. But because we recognize that there is an informal healthcare sector, regulation becomes all the more, preemptive, and therefore we're very wary of trying new things which we know we cannot control. So adaptation, of technology for public health is therefore going to be very, they're going to be baby steps. We are really going to be very watchful, but there are obviously certain, the findings are very significant. So let me just try and give you a sense of $9,000 per year. Of course, is a huge spending, but that is how consumer spending usually rises with income. In fact, within India, if you look at cross state, then Kerala has one of the largest spendings on healthcare. Not just because through the government, but also private, and which is where I'm not sure whether spending is really what we need to lower necessarily. If the costs come down, and if somebody wants to get the 10th plastic surgery, we are in a liberal market, it's fine, because somebody is bearing the cost and there's no distortion or inefficiency that we really which will have broader contagion effect in the market. So as long as it is private decision and it is within the regulated market, I think we should be fine. Now, in terms of public versus private, the first thing that struck me is when you said 66% of calls when you do to a public insurer, you are less like you're not likely to get an appointment, while it's 11% for private, and that's a great experiment, first of all, because right now in the Indian case, we are really not making a big distinction between private and public insurance yet. But a lot of our research has basically shown that given that the government is relying a great deal on health insurance as the mechanism for financing, in fact, there's an over-dependence on health insurance. We seem to be picking up all the wrong lessons from the U.S. so far. And that is something we want to be very, very careful about, because our claims to coverage ratio, meaning amongst the ones who are covered, what is the number of claims, is actually much lower for the publicly financed health insurance scheme. Which tells you that obviously, in incomplete markets with very little connectivity, with relatively less literacy, and financial literacy when it comes to insurance becomes an even bigger concern, because if you're not paying for it, they don't know that they're covered, and if they don't know they're covered, they're not going to use it. So the interventions will have to be so widespread for them to work here that it really requires multiple different interventions at the same time. Even as simple as just if you look at just the financing aspect of it. Now, the one lesson I figured from the different retail clinics, the direct consumer telemedicine, the algorithm based, that for me was the most interesting. I didn't know something like that existed. And yet, when my baby fell sick, the first thing you do is go and you do a baby center check, and then they tell you, no, it's okay. So we've all done that, and with a skepticism, because it's possible for tech solutions to really, help overcome these costs and imperfections in the market for standardized health needs. So the more standardized the health need, the greater the reliance on technology and lesser the liabilities. But the minute we get from the primary into something secondary, obviously not tertiary care, but secondary, that's where the gray area becomes. We're not sure how much reliance on technology can be there for secondary care or any kind of specialty care. So it would be great if there are experiments, particularly pilots, which have shown that the greater the standardization, the higher the probability of success. These are important from the policy recommendation point of view, because we are at a stage, and the motivation really for arranging this talk is the Indian government has announced the telemedicine centers with the partnership with Apollo, which says that basically they are going to open a telemedicine center in every panchayat in the country. The problem with that is that the health ministry is not involved in this decision, or well, forget the decision, even in the implementation of it. So now we have completely dissociated healthcare delivery and technology. We are thinking of healthcare as a tech solution to it, rather than involving any kind of either clinical judgment. Though the the telemedicine, obviously Apollo has a fairly wide network within the country, but we need those finer, nuanced recommendations based on some of the pilot experiments which you shared with us, which we can then share with the DITY, which is the Technology IT Ministry. But of course, the first point we have been pushing for is that the health ministry should be involved, and you cannot separate out and treat public health care to be really a tech problem, which it isn't. Now, the algorithm, when you talked about the solution, the one thing that struck me was, when microfinance moved from direct credit to mobile money, the one big noise we heard about was, but where's the touch factor? And that's exactly what we are seeing in healthcare. And healthcare, of course, is much, the magnitude is even more in terms of the risk taking. And again, it would be good to have, certain pilot, if there are results, if you could, if you could send to us. It would be interesting to push forth some of these recommendations again based on, your experience in the U.S. But more importantly, the liabilities. Not just because the informal health market in India is rampant and the state has been struggling, and I think to some extent now trying to accommodate it. Because of the HR shortages, one way we are really going about is treating Ayush as a regular, trying to give them an allopathic certification as a means of really expanding this HR constraint. And yet, it would be great to know what are those regulatory, those basic blueprints to be, kept in mind when we are finding, market solutions for these health problems. Of course, here, given again that the experimentation for public health is largely happening, at this mass scale from the government, though we have, market solutions now emerging, but we really don't have much data yet. I mean, some of them are performing very well, but it's not a pilot. We don't know whether this will work in some of the rural areas. They're working in the segments where traditionally these are like low-hanging fruits. And what you have shown us that it's not newer, it's not necessarily existing clients, but there's a, it's new set of people are really going in for much more healthcare, seeking, just, as the Kerala example tells us. Now, the antibiotics finding is very interesting. The only problem here is that we have rampant antibiotic prescriptions in India, even by the the physician community, which is the formal healthcare system. So the one worry is that how easily can some of these the retail clinics or the telemedicine centers be allowed to do some of this in India, because that is a serious concern, and now we are worried about new kinds of bugs coming up with antibiotics, which are resistant to antibiotics. So, can we blindly again copy some of these innovations, or will we need to be careful given that the context here is, a little very different and very less developed? In terms of the follow-up, what was interesting here is that while After when you showed us the difference in difference, when you showed us that after the retail clinics were introduced, many more checks happened. So retail usage expanded, but not just new, but even existing checkups went up. The probability of people going to existing physicians also went up. Now, could it be that these were follow-ups?
I should have clarified that. The existing bump up at the end was due to one problem and one problem only. H1N1 was rampant at that time, so we saw a very large increase in utilization, and then that went down. So
that went. Okay, great. But where is the follow-up going to be, or should we now narrow down the set of ailments to again those very standardized set of ailments which do not usually require a follow-up? So it would be nice to again know what are those standardized, and that requires clinical judgment and regulatory approval. So these are the 30 things for which the telemedicine centers are allowed as per regulation, because there the margin of error is low, or if the follow-up requirements are not that high. It was interesting to see that it was the more educated and the better off which accessed it, and the rural clients were really just 6%, and yet the targeted scheme worked. Now in India, it's as of now, access is very much access to healthcare is a broad problem in India for both urban and rural, but rural segment it's actually quite acute because majority of our hospitals and doctors are all urban. It was good to know that the extent of discrepancy rural-urban is quite severe in the U.S. as well. But here it's quite acute. So what are those 5 things you would recommend that we extend to the government as things to look out for from the lessons in the U.S. as far as rural telemedicine are concerned?
If you go to the average U.S. citizen and say, what's most important for you is to have a relationship with my physician, to know who they are, to have that touch factor you described. So they would say, I would love him. He's great, you know him well, he has a good relationship, but as soon as an ATM opens up, they're at the ATM. And so to what degree is that touch factor? We don't really know.
I suppose, just if I may follow up, that was the crux of the question was, is there work showing in India, is it equivalent to the Indian quality, or is it equivalent to...
I haven't seen anything, but I don't know if anyone else has seen anything.
But given the example Rahul gave of Chhattisgarh, if the 5-year MBBS is doing as well, the 3-year non-MBBS is doing as well as the 5-year MBBS. But for certain ailments, again, it goes back to the standardization and the obvious things. Obviously, there's a reason.
But I will push, though, in terms of every time we've tested, in terms of this work. Look, I recognize I'm a physician, so I'm challenging, my colleagues are not very happy with me. But every time we look at the care and we expand it, at first we said, oh, just simple problems. And then we said full primary care and full every problem. Then we just started doing specialty care of endoscopy, where you go down and look in the stomach. And we found that the care versus a nurse versus a gastroenterologist who has 9 years of training was equal. And so how, where that line is, I don't know. All I know is the line keeps on growing, expanding. And so we should always challenge ourselves and challenge my own colleagues in terms of when is that training really critical and when is it not. And we're learning frequently that it's not as critical as we might have thought.
So a couple of things. One is the evaluation that we just discussed about how to compare different levels of sort of trained professionals. So one of the organizations that I represent, Sugawar Healthcare, is also trying to do this evaluation with JIPMER. We have been using Ayurvedic doctors and training them to practice allopathic medicine. This has been on for about 7 years. This is in a very limited geography in Tanjavur in Tamil Nadu. But now we felt the need to actually look at the effectiveness and the scalability of the training that we are providing. We are doing this with U.Penn School of Nursing, and contextualizing a lot of their nurse practitioner modules for the physicians here. So hopefully we will get some answers, especially at the primary care level, although there are lots of, I think, international studies which are there. The other thing I wanted to understand from you is how how much of clinical protocols or decision support systems or care pathways do you use in some of these innovative models for the practitioner to actually provide care?
Yeah, I think it's a very important question, which is that in general, despite great interest in day-to-day practice for a physician in the United States, there's very little clinical guidelines or forcing mechanisms. In my practice, when I take care of patients, it's very infrequent. It's all in my head or in the, doing it. And there's a lot of interest, but in day-to-day practice, in these innovations, in these innovative models, much more emphasis in terms of doing that. So when a nurse practitioner sees a patient in a retail clinic, she must go through those algorithms, and she's forced to do this. And because everything is in a structured field, she can be audited on a regular basis. For you to evaluate the quality of my care, it's very complicated. You have to go to these charts, you spend a lot of money, it's very difficult. But if everything is in a structured format, they can audit and feedback. So there is at least the potential mechanism for you to be better, to monitor quality on a more frequent basis if you are using a more structured environment. Well, I would argue it needs to be even more structured, but there is some more of that in these innovative models.
Please.
Hi, my name is Priya. I recently founded an organization called Health at Go, and we work with school health programs. So the aim is to implement school healthcare and school medical tests that need to be there in preventive health in schools with kids. But one of my major questions that I didn't find in your presentation, it's actually about two things. One is about medical data and standardization of medical data, and what you see, like a lot of innovations in medical big data. There's a lot of artificial intelligence work that's happening. How we can use this data to actually predict a lot of things in preventive, diagnosis and medical care. So that's one. And second is medical devices. In the U.S., I think that's another area that I would like to know from you about. What are the innovative medical devices that are being used there?
Yeah, well, first I should start with the question you didn't ask, which is interesting that the school-based care, one of the frustrations for any of us who has children is the difficulty in school. Everyone's sick at school and so forth, especially in young children. So it's been interesting, very infancy is a bad choice of words, but of using child care centers and having a telemedicine clinic there as a mechanism to try to improve care. Can we use a new kind of device, which is these telemonitoring devices? So can we use medical devices such as scales or heart rate monitors or activity monitors as a way to take care of some of our most complex patients who are very, very ill, to monitor and identify problems before they become more significant. So for example, a patient with heart failure, if we see their weight has gone up 2 kgs, we say, oh, alarm goes off in a center, and we will call them up and say, please take some more diuretic, or please, are you having trouble with your breathing? A lot of excitement on that idea, and you see many products that have been introduced in this medical device area that can do this kind of monitoring. I think somewhat surprising is that the studies that have done to evaluate whether they improve the outcomes have not demonstrated that. That we find that these devices this telemonitoring does not seem to improve outcomes. Why that's the case remains a little unclear. I think some of it, to my own instinct, is that the baseline assumption is that if a problem emerges early, I have an effective treatment to try to address the problem. And in many cases, I may not. And so all I'm doing is a new problem has been alerted, but I don't do something that's actually going to prevent a long-term complication. So that is the one issue there. On the medical devices. And then the other issue that you raised with the medical data, this is my life. I sit there with very large databases with hundreds of millions of people and data to look at it. And I think there's at least my own personal experiences, there's a bit of naivete in terms of using this data. It's all well and said that, oh, I have so much data, but it takes a lot of work to try to take that data and actually provide and introduce something actually clinically or policy actionable, because the data is a mess. I have this and that, and we had a large database of over 100 million visits to a doctor, and we were trying to investigate a very basic question about variation. But the data was so complicated and such a mess that we couldn't get any good answers. And I think that's going to be an issue, that aggregating the data, and then there's the next step of having that data in such a format that's actually useful. So that's my own personal experience.
So actually, like point of care devices that are being innovated. So for example, you'd rather not have a doctor scribble anything on paper. You'd rather have him select from a bunch of options, or you have to have him give a certain input that is readable by a computer, so you can kind of analyze that input. So I know that there are some medical devices, the medical pens that the doctors can use that convert their
Illegible writing.
Illegible writing onto something more readable. Or for example, if it's a standardized kind of test that they're doing,
I'm going to hide my handwriting right here. Sorry, there you go. Sorry.
And so those things I think are also interesting. And the stethoscopes that are coming out, that anybody can use them. A physician doesn't have to be there. Because you said the low cost, hiring low cost people to do these things can only be possible, I think, if the devices are smarter that are being used. So if it's a stethoscope, I know there's so many, you just touch the stethoscope on the screen, it just displays everything that on the stethoscope screen. We are researching into that.
There's a lot of interest in providing, again, to emphasize the point you made, of how can I provide that quickly, that diagnostic testing that's necessary, so that the physician or nurse who is hundreds of miles away can listen to the heart sounds in a quick and efficient manner. And that is one thing I should emphasize, is that there is an advantage for the physician or whoever other the provider is. Often these visits can be done more efficiently, right? So that in 1 hour I can see 1.5 times as many patients. I don't have to do as much chit-chatting and other things. I can just quickly have the evaluation. So in some ways, we're using the same providers more efficiently from an economic perspective.
Great, please.
One question I had was about a lot of the innovations you showed on delivery were related more to outpatient care, obviously, and primary care. So, but I presume a bulk of your $9,000 per capita is driven actually more by, obviously, inpatient care, that's secondary or tertiary. And in India, the more uniqueness is that insurance typically only covers inpatient care, not so much outpatient, the way our health financing model works. So just curious to know, how much of these technology innovations, as you said, it's tough to predict the next curve or the next leap in technology, but how much of it do you think in the US is now already moving into inpatient care? In terms of using innovations or even technology-led innovations?
Yeah, so I think that going back to that disruptive innovation model, usually the simplest services are where places start and they grow and expand. I see less of that happening in the inpatient setting, though to some areas we do see more of it. One particular area that there's been a lot of interest in the United States is stroke care. As I think many of you know, that if someone is having a stroke, one only has several hours of time to give a medication to break up the clot. Otherwise, the weakness can be permanent. Yet you don't have a neurologist and a physician capable of providing that medication in all our hospitals or clinics. And so increasingly, there are, in the emergency departments, telemedicine to provide, so instantaneously someone from far away can examine the patient and make that decision, that very critical decision. So that is one example, but I would agree with you that most of the focus has been in the outpatient setting, and we're only seeing slight increases in the inpatient setting.
And if I may, just another related question as to how much of that is in preventive and promotive medicine? Because I guess this lends itself a lot more to that, but I guess all of your examples were more with patient leading the process. You have a problem and then you probe whether it's telemedicine or online sources.
It's a very good question, and I think that's probably a little bit of my own work that's been, as a physician, I often focus on illness care. We do see a lot of work that's been done to try to use technology to help people with better nutrition, more weight loss. Whether the studies have really documented those are very effective has been very unclear, though you would say that already the people have voted with their wrists. I don't know what it is, but everyone seems to have something around their wrist these days that's tracking how much exercise and so forth they're doing. Though I think that one thing we should be clear about, and maybe going back to the telemedicine the non-targeted, it appears to me that the thinnest people who eat healthiest, eat really well, are the ones who have these devices, and the people who most need them are the ones who do not. And so it's one of those issues that whether this is really this, if we could target those interventions, I think it would be much more effective.
Well, very interesting presentation and also the discussion. Now, of the 4 or 5 disruptive innovations that you presented, which one do you think holds the maximum potential in the US setting in terms of scale? And depending on your familiarity with the Indian context of these different innovations, which one you think holds promise in Indian setting? Now, I would like to make a distinction here for the benefit of the audience, that innovation on HMIS, management information system, in HR management, in fixing supply chain management issues, and also in task shifting because of the scarcity of HR. Now, this is different from innovations in service delivery, right, what you presented.
Mm-hmm.
Now, which of the models that you presented you think has great potential in the Indian setting? Recognizing that, our brick and mortar model is dysfunctional, it's broken. And it's here some of these scope of some of these disruptive innovations is not so much in substituting that brick and mortar model, but in complementing, in kind of fixing that model and complementing it.
Oh. So I think that I will answer your question, but with a caveat, which is that here I'm venturing from data to my own opinion. And as someone who's an empiricist, always has some degree of leeriness of going down that path, but I think your question is very reasonable and so forth. My own instinct is that the model that seems to be, for me, that has the most potential is the one, a mechanism to quickly get somebody else's input in terms of their care. The reason I think that this has maybe the most potential benefit is that, first, it is a mechanism to prevent people, in many cases, sometimes high-cost specialty needs. And so therefore, because many times instead of going to the specialist, they can answer the problem very quickly and effectively through the provider that the patient knows well. You know the physician, he sees you, he does a thing, and a day or two later he says, I think we should do X, Y, or Z. You find that you already have a relationship and you don't have to go someplace else and potentially decrease the spending. The other reason I think it has the most potential is it has an educational component to it also. That if it's a way that these physicians who are out there in practice, who have not had any training for long periods of time, decades, now are getting constant feedback, such that, let's say I have a problem, I use the thyroid example of a patient with hypothyroidism, and I say, oh, what should I do with this particular patient? Now the specialist says you should do X. The physician's like, I didn't know that this was available, I'm learning, so then we'll apply it for all of his patients. Or it's a teaching mechanism to know that this rash is eczema versus psoriasis and this is why. It's because it's going through the existing provider, it provides that educational and in some ways auditing feature too. If a physician is asking
it's like
really
a second opinion.
it's a second opinion. Or if the physician is asking really stupid questions, then you might be like, well, who is this physician who's out in practice? So because that eReferral model is potentially more efficient in terms of not requiring care that's to move for the patient to go someplace and replace specialty visits, as well as having that educational and auditing feature, I think it has a lot of potential for taking the existing workforce that's providing care and providing a mechanism, and in a manner that's much better. Because if you go and put me in front of a boring lecture in terms of what's the latest drug for heart failure, or it doesn't mean as much. But if you tell me how to take care of my own patients better, hands-on, it's going to be probably much more effective. So I think this is my anecdote and my own opinion, but I think that e-referral model has a lot of potential. And it also is not replacing that, because you do, as much as I understand there's limits on the supply of providers we have available, we should still take advantage of those providers and train them and improve their care, and this might be a mechanism to do so.
Madhu?
I probably missed the first part of your presentation. But how many of these innovations, particularly telemedicine, have been, their impact has been rigorously tested through some kind of RCTs or something? Because, I believe in medicine, there are lots of solutions which make sense, and then when they are put to the test, suddenly you realize the impact is very minimum. For example, these rapid teams that you used to have in the emergency room, and suddenly you realize that these rapid teams have no impact whatsoever. Seem obvious, but then when they were put to a test, actually doesn't have an impact. So are these innovations that you're talking about, have they been rigorously tested through some kind of randomized controlled trials, or they just make obvious sense, so therefore that's the
Yeah.
impact you're looking at?
So I think you have the right skepticism in terms of things that make obvious sense beforehand often don't bear fruit. Example, the rapid response teams that were studied in emergency departments. The work that's been done on telemedicine work in terms of there have been many clinical trials that have done randomized trials. In some cases, I mentioned the telemonitoring, where surprisingly it did not improve the outcomes. The work that's been done most is where people have been randomized to telemedicine versus non-telemedicine and studied to see whether the diagnosis and treatment is similar in terms of their outcomes. And there I would say that not everywhere, but consistently the outcomes have been, the diagnosis has been similar. So for example, in the UK, they might have had a model where half the women were told to travel someplace to see someone, and half the pregnant women were told we will do via telemedicine. And they then look to see whether the outcomes are similar between those two groups in terms of how often certain things are diagnosed. And those generally have found that things are equal. The question that you might ask is that's the wrong question, which is let us take a group on a population basis and say half the patients will be offered, this is telemedicine versus in-person. Let's choose a different question because sometimes in-person is not available, and let us take a population of people for whom nothing is available, and half of them provide telemedicine and half of them continue the current course of care, and to see at a population basis, does it improve outcomes? That has not been studied. So there is that distinction there, but again, at least comparing in-person versus telemedicine, that studies have been done, and that has those have been shown most typically similar.
May I ask a follow-up question to that? At least in the Indian context, there's a study that was done in RCT which was sending actors to government doctors and quacks, and the diagnosis was very similar. So it turns out the study said that quacks are better, at least the cost of training them is much lower than the cost of training the MBBS. And you're talking about privately also MBBS. So in that case, I mean, what I'm a bit worried about these innovations, suddenly you realize that now we are questioning the quality of medical education itself.
Care. And so going back to the whole antibiotic prescribing and my point that the quality of care was so poor that to show you're equally poor is not that useful. This maybe takes it to extreme versus the quacks versus the MBBS trained physicians. But I think that it at least has been a useful exercise that people have, this kind of innovations have been a way for people to look within the physician community, see how well are we doing, because we're being threatened by an outsider and we need to react. So in some ways those competitive forces have allowed some monitoring and better. Whether it's made a substantial improvement, I leave it at that, but I do think it's an important point.
We'll have one.
Skepticism is from ending, I read this book, ending 20 years later that those things actually don't work, after billions of dollars have been spent.
We're very good at that in healthcare.
Okay, we'll have one last question and then we'll take it out. We'll discuss outside.
I'm Kannan from the George Institute for Global Health. I had two questions. So one is, has there been a study of the social factors responsible for the uptake of these innovations? I'm curious to know this because I presume there's a high level of care-seeking behavior in the United States, and it would be quite different in the US where in the rural areas, you have to promote care-seeking behavior before such innovations are actually brought in. So A, what are the social factors responsible? And B, I'm sure there is big marketing around many of these things. So has there been an effort to promote healthy skepticism of these innovations?
Yeah, so I think the easy answer is the last one, no. I mean, the advertising has always been on the, let's use this more, it's better, we can provide, this is great. So the skepticism has not been encouraged. I think you raise an interesting question, which is I can tell you from our studies who uses these things on a very demographic factors. I can tell you their age, their gender, how many illnesses they have, their care-seeking behavior before. But I am very curious, and I don't know if, where I can only provide limited answers for you in terms of what's the personality and other social factors that are driving people to use these clinics. For those who, in the retail clinic setting, we did do a number of studies where we actually interviewed patients and said, what drove you to this clinic? And I would say it was really broken down into two groups. Those who had insurance, it was all about the convenience. They would describe, I'm working, the two of us, my husband and wife, are working, our child is sick, it's very difficult for us to take time off of work. I call my doctor's office, it takes 3 days to get in. Here I can get in right away, after hours. It's the convenience, getting in quickly. For those who were uninsured, it was interesting, it was very much driven by the price. Because there they knew that if they went to a government clinic or another clinic, they wouldn't know how much it would cost. That's one big problem in the U.S. healthcare system. Because of the insurance system, the prices have become less transparent, so therefore they would be they would go and be charged
Which is
large.
why they have menu.
And so they have a menu here, and so the fact that it was a large amount of money, in the U.S., $60, $70, $90 is a lot of money, especially for our poor, but they at least knew how much it was going to cost. And so that was very valuable. The certainty of that cost was a really critical factor, not the actual difference in cost. That gives you very little, but I think you're asking a very important question, and I don't know if we have the answer yet in terms of the social factors that are driving interest.
I think one litmus test would be the impact of some of these on insurance cost itself. I mean, eventually, if you're going to be giving out more information, either through these or making it more transparent, but also just lowering the cost, the base costs coming down. And if insurance premiums come down, which is too much to ask for, but if they do, then we know that the general equilibrium, in some sense it is leading into price.
Yeah, so so it's a very, though it's complicated by so many other factors, and I would go back to the issue that also hospital-based care and some of the other care really absorbs so much of the spending. To see the marginal differences between this type of care is hard. But.
Great, thank you very much.